this topic kind of evolved, and I originally I was told that I would be speaking to you on the pediatric vaccine, but then the Omicron variant kind of slipped in there, so we'll discuss both. All right, and we'll go from there. I'm going to start out talking about Omicron though, because there's a lot of discussion in the atmosphere about it, and so we just want to kind of demystify what's happening. So the objectives we're hoping to accomplish before we end our call tonight is to identify what is known about the COVID-19 variants. We want to discuss what we need to know about COVID-19 Omicron variant and outline some of the emergency use authorizations that are available right now for the pediatric COVID vaccines, talk about the pediatric clinical trial results, and then evaluate the response of the federal, state, local government when it comes down to the variant coronavirus outbreaks. And I'm just going to say this, we are not out of the woods. And I think all of you realize that. Just on this past week, on Friday, I was at actually at the Miami Rescue Mission's Christmas gathering. And on Monday, I got calls from administrators saying there were about 2 or 3 people that had tested positive for COVID. In fact, were sick with COVID from that gathering. And then on the next day, when I was doing vaccines, I got another call that people that I was in the immediate environment tested positive for COVID. And a lot of these are these young people, by the way, and we'll talk a little bit about that. And the last one was actually, and I spoke with Dr. Rams-Johnson on Sunday. I did vaccinations. I was scheduled to be with Keeping the Faith. And of course, I didn't see anyone. And so I went to another event and I was able to vaccinate, and then found out that there were 2 or 3 people there that tested positive for COVID. So I said that to say this: we cannot allow our guards to drop. These variants are real, and they are continuing to mutate. And when you hear the word variant, of course, you know, it varies from what the original state was, but it is just as deadly and problematic. So let's talk first about COVID vaccine variants. On November 26th, and I actually have a timeline later on, and you'll see this again. On November 26th, the World Health Organization announced a new severe acute respiratory syndrome coronavirus known as Omicron, and that's the B11529. And it listed it as a variant of concern. And I'm going to talk about these different titles that the CDC has provided for us to follow and track what is happening with these variants and how much they are on the radar. I'll use those terms. The Omicron variant, it carries an unusually high number of mutations, so far around 32, and they're all on that spike protein. In previous presentations, I've shared with you where we look at this S spike protein, and then it has the N, but this is the main antigenic target of antibodies, and it's generated by either infections or vaccination. So it's the prime area, target spot, so to speak. Now we are just still coming out of Delta, and Delta has caused a lot of problems, and it has also caused a lot of deaths. But in comparison, the Delta variant has only 5 S protein mutations compared to this Omicron. So you can see how rapidly the Omicron variant is moving. And we know that the Delta variant posed a high potential global risk, and it has already spread internationally. But again, the Omicron has also traveled around the globe. So the mutations on the Omicron variant are widely distributed on multiple proteins. And you don't have to remember these, but these are the different proteins that it has found itself and has attached to. And they envelop themselves, and this is the membrane proteins, and we're not going to go into that because I think what's important to know is that the Omicron variant right now actually is 10 times as potent as the Delta. And I don't want you to lose sight of that. So the focus of these mutations, again, is on that S protein, which is your receptor binding domain. And I'll just show you a couple of pictures and things just to refresh you from what we've talked about in the past. So let's look at these variants. In 2019, we had the alpha, and that was the B117, because they're all given numbers. Then we had the beta, gamma, and look at how this is going, the delta, epsilon, I just grouped them, epsilon, eta, iota, kappa, zeta, theta, lambda, mu. And I know many of us had no idea that these many variants have been traveling among us, but they didn't seem to latch hold or get the attention that the Delta and the Lambda and now the Omicron variant has attracted since that time. And when we look at these classifications, as I said, I just wanted to go over them. These are the classifications. You have the variant being monitored, VBM. You have a variant of interest, which is VOI. You have a variant of concern, and then you have variants of high consequence. So let's look at this. These 4 classes is very important for us to recognize. So the ones that's being monitored, meaning they're out there. You may not have heard a lot about them. They may not have impacted you, but it doesn't change the fact that the SARS-CoV-2 virus has been mutating. And so these are being watched to see what happens with them. And then the variant of interest is currently no SARS-CoV-2 variants are designated as one of interest at this time. It doesn't mean it's not going to change, but at this time. And when we look at the variant of concern, well, guess who they are? These are closely monitored and they are characterized by federal agencies. So we have the Delta and we have Omicron. And so those are the ones right now of concern that it has the attention of the World Health Organization and the CDCs around the world. Then we have what we call variants of high consequence. And today, right now, we don't have any variants of high consequence that's been identified here in the United States. It doesn't mean that it's not going to change, but that means that when we hit with the pandemic, if you remember, that was a variant of high consequence, SARS-CoV-2. But we, through vaccinations and other measures to protect the public, it is no longer considered the variant of high consequence. What we're concerned with now are those that have mutated. And when we talk about this, the spike protein, the glycoprotein of the beta coronaviruses, and early in 2020, I talked to you about the different types of COVID coronaviruses. You have alpha and beta. We have been dealing with the beta coronavirus, and it's a homotrimetric class fusion protein, and it exists in a metastable conformation. Don't worry about this. It's just information. However, what is important is that it undergoes substantial structural rearrangement for an ACE2 host cell receptor binding. And this is important for us because this is one of the major binding sites for that spike protein, okay? And again, it's densely decorated. It has that end-link glycan, it protrudes, and we'll look at that. And you can see this in study after study after study. And if you recall, this is an old slide that I used very, very early on, where you can see, and I'm going to use my pointer here, you can see this S protein, this spike protein. Here it is here, and again here. But if you look at some of the others, it's not at the end. This is not a terminal link. But this is what is being used right now by these variants to attack and to gain entrance into the body. Again, looking at it, you can see the different variations of the spike protein here. This is closed, but this one actually is open, and it allows attachment of the variants. And once it attaches, then you know what it does. It penetrates, it gets inside of the cell, again, the cytoplasmic area, then it takes over and it begins to multiply, and then it destroys those healthy tissues. So again, talking about COVID-19 binding sites, We look at how the SARS-CoV-2 enters the host cell. It initiates that infectious process. And then we have what we call binding free energy between the S and the receptor binding domain. So I'm using these abbreviations, but that's what it means. And the ACE2 is proportional to the viral infectivity, meaning the more it becomes infective, the more it takes hold, the more of those receptor binding sites are bound up at the ACE2 receptor site, the sicker the individual is going to be. So an antibody also, and I didn't put that slide in, but in one of the earlier slides in another presentation, I showed that when the antibodies are in place, it blocks that binding site so that then the variant cannot infect you. It cannot enter, it cannot do you any harm. So again, an antibody that binds strongly to the receptor binding domain will neutralize the virus. And this is what we are trying to do. Through the vaccines, through the buildup of our antibodies, it neutralizes the virus. And so then the virus cannot do the damage that it has done or cause death within this population once we can block it. So again, there are many receptor binding domains and antibodies. They're generated by the body. And again, you know, it's a human immune response, and it happens to infections or through the vaccination. The monoclonal antibodies, they target the S protein as well, and particularly, again, the RBD, which is the receptor binding domain, and is designed to treat the viral infection. So this is why the monoclonal antibodies, if they are initiated early on, then it can treat the infection and it reduces the adverse sequelae to this virus. Any mutation that takes place on that S protein, and remember when I showed you a few slides ago how those different SARS-CoVs have mutated and changed, so it will cause immediate concerns about the efficacy of existing vaccines. And this is why they say, well, we're not sure if the current COVID vaccines will work against all these variants. You remember hearing that out in the community, the public notices and things. Those are concerns. Why? Because every time it mutates on the S protein, we are not sure how efficient the vaccines will be. But what we're finding out is that it is holding. So when we look at those antibodies and the potential for reinfection, you can see this occurring because of these variants, better known as mutations from the original SARS. So again, when we have this binding free energy induced at these specific receptor binding domain mutations, this indicates its potential ability to strengthen the binding of the S protein. So a negative, and it's counteractive. So a negative binding free energy change suggests a likely capacity to reduce the binding strength of an S protein antibody. I'm going to repeat that, and it's there for you to read. If you have a negative binding free energy, it suggests a likely capacity to reduce the binding strength of that S protein at the ACE antibody complex. However, if you have a positive binding free energy change that's induced by a specific RBD mutation, it indicates the potential and ability to strengthen the binding of an S protein at that ACE complex. And that's what we want to see. And these are Omicron mutations induced binding free energy exchanges. And it looks crowded, but I want to draw your attention to the bottom, these colors. The first binding free exchange changes here is with the Omicron. Do you see how much of this is colored in blue? You notice that? So that tells us that it is saturating. It is on a negative for us. Look at Delta. This is the Delta changes with binding free energy. And remember, it's an inverse type of reaction. So if it's negative, you are not going to get the binding capacity that you need to protect yourself. This one is actually Omicron again, as it's changing. And then this is the Delta. So when you look at this, these mutations, we are actually evaluating how well our body's antibodies are able to protect us against it. So let's look at this Omicron variant. And did this go backwards? I'm trying to think. No. Okay. On November 30th, the Omicron was classified as a variant of concern. And how did they determine that? Well, it was based upon a couple of things. First, detection of cases attributed to Omicron, and that's in all these different countries where it has presented itself. And at the end, I have another slide where I'm going to show you the chronology of it, including among those without travel history. Transmission and replacement of the Delta variant in South Africa, where we know that a lot of this was first originated or first identified, let's say detected. The number and locations of substitutions in the spike protein. This goes back to what we just discussed on the number of mutations that we are seeing with Omicron. It has 32. And then the available data for other variants with fewer substitutions in the spike protein. And that indicates a reduction, again, in the neutralization by sera from vaccinated or convalescent individuals. And again, the whole purpose of those vaccines to initiate the immune response through our antibody system is to neutralize those variants. So if it binds up that site, then the virus can't enter. And this is what we are trying to achieve through everything that's being done through the vaccination program and also what KTF is doing. So, and the last issue or area that makes it a variant of concern is the available data for other variants with fewer substitutions in that spike protein. And of course, that indicates reduced susceptibility to certain monoclonal antibody treatments. You don't want to have to know that you have contracted COVID to find out that because of all these substitutions that the monoclonal antibody treatment is not going to help you. And so again, this is why the Omicron variant now is seriously a variant of concern. So what is the response to the Omicron variant? Well, essential infectivity and antibody resistance of the SARS-CoV-2 variant are determined by its mutations. And I've said that, and I hope that that grants and takes some traction with you in this presentation, because what are we looking at? And if I had to do a post-test or review, you would tell me it's looking at the receptor binding domain. And we also have to remember about the binding free energy that is released from these variants. So based on 132 three-dimensional structures, and this is what they're doing, this is what science has provided for us. They are looking at the structures of the antibody receptor binding domain complexes. And so they're literally in laboratories creating models to, I guess you want to say, super guess or a scientific guess on what variant is going to come up next. Which way is it going to change? How is it going to twist itself so that we can be ahead of it? So Omicron may be twice more likely. Well, let me go back. I missed this line. Omicron may be over 10 times more contagious than the original virus, or about twice as infectious as the Delta variant. So you can see from where we started with SARS, and we know what the death toll looked like. We knew what the morbidity looked like. This Omicron virus is 10 times more contagious than the original SARS-CoV-2. Omicron may be twice more likely to escape the current vaccines than the Delta variant. So this helps us to frame this discussion that it becomes a variant of concern. So the FDA has approved these monoclonal antibodies for us from Eli Lilly, as you know, and we're thinking that it could be seriously compromised. And the Omicron may also diminish the efficacy of other monoclonal antibodies. All right, so keep that in mind. We want people to go and get the monoclonal antibodies early on when they find out that they have COVID, especially if they're, in that at-risk group. But what we're finding out because of the potency of this variant is that the different production companies' antibodies may not be as effective. Okay, the good news is the impact on Regeneron is mild. So that's a good thing. Again, just as a reminder, as you look at the SARS-CoV-2 or SARS-CoV, remember it's the spike proteins. And now you can see it looking at this, and now I'm using my mouse here, and the receptor site is the ACE2. This is just an example of antibodies, of course, when you look at the antibodies with the Y and if we have the antibodies, it blocks the variant. So there is no entry. The person cannot get COVID. They cannot get sick from COVID. And this is what we're trying to achieve. But look at the binding free energy changes here. And this is because of the amount of energy or in kilocalories that's produced. Take a look at this. Look at alpha. Beta, remember beta when it started out? We were worried about that. Gamma. Look at the increase in delta. But take a look at this. Lambda was a variant of concern early on. But then came along the Omicron. Look at what it's doing. This is very serious. So we cannot ignore that. So I'm going to thank Dr. Rance Johnson and Ms. Sewell for adding that to our discussion, okay? Because we really were going to talk about, as Dr. Holder said, the pediatric vaccines. And this is just another schematic showing the interaction of those receptor binding domains with the ACE2 inhibitors. Don't worry about the numbers. That's for another day. And again, showing these binding sites. And this is what we're looking at with the interaction between the binding free energy that's taking place and how, again, remember, if it's negative, there's a more likelihood of you getting COVID, the Omicron variant, all right? Versus if you have a strong positive binding, then your chances are much better. And I'm going to skip over these because this is all just showing. And so with that, I'm going to stop with the Omicron. I'm coming back to it near the end. Do you have any questions for me before I go into pediatric COVID vaccines? Any questions for me?
No, thank you. That was a great review. And I hope everyone sees why we're concerned. But the results coming out of South Africa has been showing mild disease. But what are but many of those people may have already had the earlier infections because nobody really knows, they didn't have vaccines. So maybe that population is heavily infected, they feel. So they're seeing a mild infection. Have we seen anything coming out of Europe, what they're saying? Are they also pretty much staying mild with vaccinated?
Exactly. This is exactly what they're seeing. So right now, of course, the data is still pouring in and we're trying to grab it. And that's one of the last slides I talk about, what we're doing, what is the federal government doing, how we're monitoring this, but there's a lot of monitoring and surveillance, not just here in the United States, but globally. And we are now finally sharing this information. And I'm going to share the timeline with you as well.
Right. I was wondering, I haven't seen the data yet on unvaccinated, especially unvaccinated older people with Omicron, because most of the global South, as we know, who have had, they're all young. So they're going to have mild disease anyway.
Correct.
So
that is correct.
But the variance is not surprising. It's it's like HIV. I mean, it's billions and billions of particles are made with every infection. So you do expect variants and you expect drug resistance and everything else, because that's how the virus works. So I hope.
Exactly. And Dr. Holder, you're so right. And so we kind of forget that, you know what I mean? We just say, oh, that's COVID. But this thing is mutating. And I showed you in that, I don't know if I can go back to this.
Yeah,
this
that's
slide.
why we encourage folks not to get infected, wear the mask, do as much as possible, because every infection needs billions and billions of particles, which increase your likelihood of something coming out terrible.
Exactly. And if your antibodies are not there and your binding free energy is not where it has increased that capacity,
right?
As you see, it'll enter.
Yes, it will.
You have the breakthroughs. So, you know, I don't know how to overemphasize the need for these vaccines. And now we're able to give it to our children.
Yes.
So let's talk about it.
Dr. Brown, before you go on, we have a question from Mr. Hassan of the Islamic Center of Greater Miami. And his question is,
I'm trying to get my my speakers to I can't hear you that well, but go ahead. I hope you can hear me well.
Yes, I can hear you. Can you hear me?
Great.
Okay. His question is, why are there so many side effects with the booster shot? And should we go ahead with the booster, even if it might not be effective against the new variant?
Well, first of all, the boosters do have an effect against the variants. So let's just put that out there. Once you have received those vaccines and your body has mounted an immune response, you absolutely have some degree of protection. Now, we realize that those variants, in other words, we realize that the SARS-CoV-2 has mutated into these different strains that we're seeing, but guess what? They are still targeting that S spike protein and the ACE receptor site. So that's a good thing. And so if you're mounting the antibodies that are needed, as you could see, you have some protection. And it's better to have some protection than no protection. And we found in the research, it showed early on that some of the antibody response had waned. In other words, it was dropping. And when it was dropping and you hit it with another boost, it boosts your system up, right? So now you got another overwhelming group of antibodies that's out there ready to fight for you at that site. Because remember, these are specific for certain diseases. And so now and I shouldn't have said booster, I should have said the second shot. Now, when you get your booster, that booster actually produces, I call it a cascade. I mean, it's almost like a complement. And when I say complement, what I'm talking about is that your cytokines, your body says, wait a minute, what is this? You know, and it wants to now really come out very forcibly to protect you. So, and I use the example many times of someone injuring themselves through an open cut or a banging a body part. And one of the things that you feel first when an injury occurs is pain. Why? Because those receptor sites now are triggered. Not only that, you have all of the macrophages, and you have your cytokines, you have everything going there, that all of these body functions to help protect you. It's all part of boosting the immune system. So what happens when you have complement, and I tell people, I said, one of the things you can get fever, you can get pain, you may get some swelling, you may get some redness, you may feel tired, because your body has now provided what we refer to as an overwhelming response to that mRNA vaccine or to the viral antigen, whichever one that you have received. So when you talk about why is the booster causing so much, it's because your body is responding in a way to an overwhelming hit. But guess what? As your body now comes back down to normal, and now it goes into a higher level of memory cells, better known as the memory cells and the T cells, and your B cells as well, you now are protected. So that's part of what's happening. And the research that is produced, and you'll see it when I show you this about the pediatric population as well, you expect to see certain responses. And that's a good thing. It's not a good thing when you have to feel the pain and you're too weak to get up, or you start having swelling in your arm and under your arms and headaches and all of those types of responses as the body kicks back or increases the antibodies that will be needed to block the virus. And that may not be exactly how you want to hear it. And I'm just trying to stay away from too many like technical terms, but this is what's happening. This is how the body responds anytime there is something foreign that enters into the body or attacks the body. And it breaks that line of defense, which we know is known as the skin. So that's pretty much what's happening. Now, I want to talk about the hospitalizations by age groups. And if you look that it is actually color-coded. So when you look at the 0 to 4 age group, which does not currently have a vaccine in place for it, we still have hospitalization of these children from COVID. The numbers are not as great, but it's still there. And it's hard for you to see, but it's that little top piece right there, right across the top. Those are your numbers. And then when we get to our 5 to 17, you see that those numbers start to increase. So when you look at that color code, you're looking at the ones that are down here. Then we have our 18 to 49, and that's this group coming right along here. All right. And look at what happens during this cumulative case count. And there was a period of time, and I know you can't see that, you probably can't see the dates, but and I'm moving closer because I can't hardly see the dates myself, but it was during the months of October, let's go back, starting around September of 2020, right in this area, all the way through to April of 2021. Look at this surge. And this affected or impacted all these groups. And the 65 year of age and older here, this is very serious. And then we jump over and look at this 18 to 49-year-olds. So as the vaccines were being released, people were getting vaccinated, we saw the drop come again, down, 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 down. And then we got lax. And then again, think about this. I showed you all those variants that came through. So for some people, as you know, who had been vaccinated and they may have gotten their second dose, many of them had breakthroughs and they got COVID again. And they said, well, wait a minute, the vaccine's not working. It's not that the vaccine is not working, it's that these are variants that's coming through here. And so we saw a surge again with this. And then when we look at the underlying medical conditions that also add to the issue or the problems that we're facing with COVID, take a look at this. And it hasn't gone away. We have, and this is looking at the pediatric population compared to the adult population, compared to pregnant women who always want to know, I'm not taking this because I don't think it's safe and it's going to harm my baby. But take a look at this. The conditions, asthma, higher, of course, in the younger age group, the pediatric group. This one says the autoimmune diseases, which, believe it or not, a lot of people with autoimmune diseases have been hesitant to take the vaccine. But look at what happened. The underlying medical conditions has not impacted it to the extent that some of the others. Cardiovascular disease in the adult has been major, not so much in the pediatric population. Chronic lung disease, which you would expect because it tends to attack the ACE2 receptors in the lungs, in the lining of the lungs, but you don't see as much. Here you see, but look at our spikes here. Hypertension. This one is cardiovascular disease. This one is metabolic diseases, especially diabetes. Take a look at this one. This is obesity. These are the underlying medical conditions that have led the list of causing death among people who contract COVID. And then you look at pregnancy here. Pregnancy has its own little area, and it depends, again, as you know, there are hypertensive pregnant women, there are obese pregnant women, and there are pregnant women with gestational diabetes. So again, matching what we were seeing over here. And then the other diseases and some no known conditions that led to, and you know, there was the multi-inflammatory system conditions that were attacking the pediatric population. So again, this is what we were seeing with some of the underlying medical conditions. And this was charted from March 2020 through September 2021. So.
Question, Linda. I've always been surprised no one has ever had HIV, looking at patients with HIV. Have you seen that data?
No, and that's a very interesting one, because I did see something, I didn't put it on here, that they actually looked at HIV patients.
Mm-hmm.
But, you know, and please forgive me, I did not put it on here.
Okay, because
there wasn't a lot of conversation around it.
Yeah, the patients I treat with HIV have gotten infected several times over, but no deaths. I think because the immune system isn't strong enough to do the cytokine storm.
Right.
So they sort of get through it slowly, but they've done very well in my population.
And you know, that's interesting, Dr. Holder. So you know what you just prompted me to do, right? So you know
the research for me. Thank you.
Absolutely.
Perfect.
Absolutely. So let's talk about the pediatric emergency use for COVID-19 vaccines. The interesting part about the release of these vaccines for children is that they're color-coded. So with the emergency use authorization of this formulation with Pfizer Biotech, because they're the only ones, and I often tell people that they are first out the gate. I don't say work because I'm not paid by Pfizer, but I am one of their speakers on their speakers bureau. So I should qualify that. But they were first out of the gate. They had, and they joined in with BioNTech, which is another major technology corporation. So they were able to, with the funding and support, to get out of the gate first. And so that's why we saw Pfizer on the scene so readily, so quickly. They had everything in place to do this. And it's supplied in multiple dose vials with the purple caps in adolescents 12 through 17 years of age. And again, it's based on safety and efficacy and the data that we have presented in previous discussions. I'm going to show you the data for the younger group tonight. So for individuals 5 through 11 years of age, there is a different formulation of the Pfizer Biotech, and it has been authorized. And then we have the emergency use that we would love to have for children younger than 5. This has not been approved. So we are not vaccinating children 5 years of age and younger. The fact sheet then, and they're out there, and now they're like 34 pages. I mean, it's just ridiculous, the number of pages, but they have to cover themselves. And everything that was presented to not just the CDC, the FDA, and to all the other regulatory agencies that had to go through before they got the EUA, they have to include all of that information in those fact sheets. So that's one of the things that's very important for us to remember. So the FDA issued this emergency use, as you know, and it's an unapproved product unfortunately, for active immunization to prevent COVID-19 in individuals 5 years of age and older. There are 2 formulations that have been approved by the Pfizer Biotech COVID-19 for use in individuals 12 years of age and older, and I'll show you that. The formulation supplied in a multiple dose vial with a purple cap. If you see the purple cap, please, it must be diluted prior to use. The formulation that's supplied in a multiple dose vial with a gray cap and label does not require dilution prior to use. So this is one of the changes that's coming down the pipes, all right? So, and I just pulled this right from their website, which gives this information. So any of you can go back and pull this up. But this is how the vaccine formulation presentation looks. And we're going to go through this, all right? So if it's a purple cap, 12 years of age and older, the dose is 30 mics. We know it's 0.3 milliliters. It's 1.8 milliliters of dilution, and it will yield 6 doses per vial after that dilution. That has not changed. It requires ultra low temperature, and it's good for 9 months at the ultra low temperature freezing points. And if it's in the freezer and you don't use the ultra low temperature things in the freezer, it's good for 2 weeks at these temperatures. All right, so that's minus 25 degrees centigrade to minus 15 degrees centigrade. And this has come up in previous discussions, and I think all of us are pretty much comfortable with that. Once it goes to the refrigerator, it's good for 1 month. And if you have it out while you are vaccinating at room temperature, you have 2 hours prior to dilution, including any thaw time, before you have to make sure that it is kept at the safe refrigerated temperatures. And then after 6 hours, after the first puncture, this is after dilution, you have to discard it. Any questions on the purple cap for 12 years and older? The next is also for 12 years and older, but this is the gray cap. So please make sure you're comfortable with the difference. Purple requires dilution, gray, no dilution. Same amount of volume, 0.3 milliliters, no dilution. It still gives 6 doses per vial. It is good for 6 months. You do not have to store this one in the freezer, so there's no freezer requirement, and it gives us a little over 2 months. So you get 10 weeks of holding this particular gray cap vaccine. And at room temperature, where we had 2 hours with the purple cap, you have 12 hours prior to first puncture, including any thaw time. And you don't have to discard it to after 12 hours. Any questions on the gray? So these two are for 12 years of age and older. Purple cap, you dilute. Gray, no dilution, same dosage amount. You have longer outside of the freezer time for it, but you have to discard it after 12 hours. When we talk about the newly EUA approved pediatric dosage, this is for children between the ages of 5 to 11. It's orange. All right, so the orange cap only gives us 10 mics, not 30, and the dosage is 0.2 milliliters. You have to dilute this. This is one that requires dilution, but the dilution amount is less. It's 1.3 milliliters, and it gives you more per vial. So now you have 10 doses per vial, and it also will last up to 6 months. You do not have to store it. And again, the refrigerator time is 10 weeks, 12 hours, and discard after 12 hours. So these are now where we are with pediatric dosages. Purple and gray, 12 and older, purple dilute, gray no dilution. Our orange cap is for our 5 to less than 12, and you have a less amount, 0.2, and your dilution amount is less. Again, here is just additional reiteration of this. And this is, again, the purple cap, 12 years old, 1.8, 6 doses, 0.3. And again, when we talk about this, verify that the vial of the Pfizer BioNTech vaccine has a purple plastic cap if you're going to dilute, all right? 12 and older. So make sure you're watching those color codes, and they tried to color code it to avoid further medication errors. What's different about them? Well, there's some formulation differences. The buffers help maintain the vaccine's pH and, the stability. And I tell people about this, and we've talked in the past about what's included in those buffers and things like that. Well, the purple cap uses phosphate buffered saline. However, the new formulations of orange and gray cap uses what they call the tris buffer. And this is used in a lot of the other vaccines that are used with children. And it excludes the sodium chloride and potassium. It is stable at refrigerated temperatures, which is good, and is stable up to 10 weeks. And so for that reason, now you see that we can extend the life of these vaccines that you have in storage. And it's delivered in thermal containers with dry ice. And the storage now of the Trees products are at the minus 25 degrees centigrade and down to 15. So this is where we are with formulation. Again, looking at the 5 through 11, the process is pretty much the same. This is a reiteration. Orange, 5 through 11, 1.3 dilution. You get 10 doses. You're only given 0.2. You always verify what you're doing. This does require dilution. As you know, it can be stored in the refrigerator for up to 10 weeks prior to use. And that's very good. And again, with the dilution, you gently rotate it 10 times. And after you've done that, you're going to, before your dilution mix by inverting your vaccine, and you're going to add your air. You know that once you have provided your saline dilution, which comes with it, and you obtain sterile 0.9 sodium chloride, and they send that, actually the dilution comes with it. And you're only going to add 1.3 milliliters to it. All right. And this just goes over the method of the procedural method of how we do that. We draw up our air, we pull it out, we inject it, and then we pull out that equal amount. And that's what we do. And you equalize the valve pressure before removing the needle, because guess what? If you don't equalize it, you're going to lose the vaccine in there and it's going to squirt out. Same thing applies when we use the 12 years and older. Now, remember, gray, there is no dilution. Do not dilute, 0.3. And again, always check it out. It stores for up to 10 weeks, just as the other. And the basic processes are the same. You put in the amount of air you need without adding any dilution, and you withdraw 0.3 tenths of a milliliter. So that covers how we are going to give. And where we give it, I didn't do that, but we still use the Deltoid. And this is for your 5 to 11, and this is for your 12 and older. All right. Now, I'm thinking if we ever get the smaller doses, then I'm sure there will be literature that's going to come out about using the vastus lateralis for them, or the lower extremities. So we'll see what happens. So let's talk about the clinical trial results from this. And so what we have here, we look at the
Dr. Washington Brown
discussion where people have been concerned that they felt that we didn't have enough participants in there. But let's just look at what happened. And you can see the major overarching reports: fever, fatigue, headache, chills, vomiting, diarrhea, and new or worsened muscle pain. So all of these actually occurred with the children. Okay. Now this is within 7 days after each dose, and we'll look at the doses, adolescents 12 through 15 years of age. So when we look at this, you can see with fever for the first dose, it was about 114, 10.1%. But let's go over. You didn't have as much with the placebo, so we pretty much know this was attributed to the vaccine itself. Here, we had 19.6% when we had the second dose. So again, remember, this is not done in a vacuum. This is really happening. And this is talking about the degree of temperature gradient in centigrades. So you can see how, as the higher degrees, you can see more of the responses from the recipients. Fatigue, mild fatigue, 60% in the first dose, 66% in the second dose. Moderate, only about 24 and 21, and you can see how they equilibrate. And then we get to severe, you see it's less, but it still has occurred in recipients of the vaccines. And again, the placebo, they still had it, even with the placebo, but of course, in very, very small increment amounts. Headache is another one I hear often when I give the vaccine. You know, I just had a slight headache, but let's look at it. Any kind of headache was 55% in the first dose and 64% in the second. However, mild headaches, 32%, 27, you can see this. Moderate, 22 to 35 in the second. It was a little higher though in the second dose. And then when we look at severe, it was still a bit higher with the severity of the headaches. Chills, again, I'm not going to go through all of this, but you can see that this happened. Even vomiting. People vomited after getting the vaccine. Some people developed diarrhea after receiving it, and muscle pain. So muscle pain was like any kind of muscle pain, 24%, 32% after the second dose. And even in the placebo, they had it. So again, if you have experienced any of these are findings from the studies that we know. And that's why when we give you the handout, said these are some of the things that you can expect that's going to happen or could happen following your vaccination. And so it bears out that this did occur. And in this one, as we look at this one, this is looking at the frequency and percentages of participants with local reactions. And again, you can see the redness, the swelling, and this is looking at both the dose 1 and dose 2. I'm not going to go through all of this, but again, you can see it, pain at the injection site. You would expect 71%, 74% of any kind of pain is expected. And that's what we saw. Okay. And so if this actually happened, and let me make sure that we see this was from the 5 through 11-year-old children. So for those parents that are ready and prepared to have their children vaccinated, please do know that you can expect the same or similar responses in those children from even the small vaccine doses. Okay, hold on, let me see, get this to move. So the good part, now you're supposed to report these, but most people are not reporting it. I'm sure the VAERS system is being overwhelmed, but if you are having it, if you're having any of these, you can self-report. Here is the website, fax number, or telephone call. All right. And I'm sorry. And even when we talk about the risk summary, all pregnancies have a risk of birth defect, not just because a person has had the COVID vaccine. And it talks about the background risk of major birth defects and all of this. So if any of this happens, they found that the toxicity study of 0.06 milliliters of vaccine formulation contained the same quantity of the messenger RNA at 30 mics. So again, it's an individual decision, but we do know that pregnant women can have the same or similar responses, and there could be issues during the pregnancy that can occur but could occur whether you got the vaccine or not. And so I do need to reiterate that. And they looked at it when they vaccinated female rats through the intramuscular route. And they looked at them at 21, 14 days prior to mating and on gestational days. And there were, according to that particular study, no vaccine-related adverse effects on female fertility, on fetal development, or on postnatal development were reported in that particular study. And I do know that there are some studies that are out there from pregnant women who have had the vaccine. And so that information is available to us. So what is the federal, state, and local government's response to these variants that we're dealing with right now? And I said I had this little chart prepared for you. And if you look at the bottom, it was in November 11th that the Omicron virus was first detected in Botswana. It was later reported on November 14th in South Africa. On November 24th, the variant, and remember early on, I told you how these viruses are named through the World Health Organization. They have a method, a nomenclature that they use. It was named the Omicron virus on November 24th, and that's the B11.529. And that was November, what do I have? New SARS-CoV-2, okay, was reported, I'm sorry. And then it was named on the 26th as the Omicron variant of concern. And in December 1st, where we are right now, we had our first confirmed US case of the Omicron variant, which you know now we've had several, and it is here. And so we have to do what we need to do to protect ourselves and our loved ones. So what is the federal government doing? Well, they're continuing to monitor and surveil all variants of the virus that cause COVID-19 in the United States and globally. They are actually talking to each other, the World Health Organization, the CDCs of other countries. They also provide free vaccines to all US citizens. They provide free vaccines to other countries that are in need of the COVID-19 vaccine. So hopefully we can stop the global spread. They are providing free test kits to detect COVID-19. They are also now providing free monoclonal antibodies for persons diagnosed with COVID-19. Now, I'm not going to say everybody can get it because there's a supply issue. They also provide PPEs to state and local departments of health. And they are providing constant updates on the CDC website on what's happening with COVID-19 and with all of the variants that are currently out there. Looking at the COVID-19 mortality rates right now, where we are from the time that we started, as you can see, as you look at non-Hispanic whites, Hispanics, and non-Hispanic Blacks, and this is one crude and age-adjusted percents, all right? But this one is unadjusted for age. This one is age standardized and adjusted. This one over here is crude age-adjusted COVID-19 deaths and unweighted populations. As you can see, more non-Hispanic whites are dying. But again, if you look at it proportionally, guess what? There are more non-Hispanic whites here in our country. And then we look at the mortality overview, and this is as of 11/19/2021. We have, well, you know, we crossed the $500,000 mark long time ago. So COVID deaths actually went up to 768,204 deaths. And total access deaths we're almost at 1 million right now. Where are people dying? Well, they're dying in hospitals or inpatient settings, 68.1%. And nursing homes or long-term care facilities, about 15.6%. By race, again, we already know this, non-Hispanic whites, about 63%, Hispanics, about 17%, non-Hispanic Blacks, about 15%. And then when we get to our Asians and non-Hispanic American Indians and Hawaiians, you can see that those numbers are very, very, very small. And steps to reduce the spread of infection, we haven't changed. We got to continue to do what we were doing before. We know that vaccines reduce the risk of severe illness, hospitalization, and death from COVID-19. COVID-19 booster doses are recommended for adults ages 18 and older. Teens 16 to 17 years old who receive the Pfizer-BioNTech COVID-19 vaccines can get a booster dose if they are at least 6 months post their initial Pfizer vaccination series. What else are we doing to stop the spread? Please continue to use the PPEs. It is effective if you use it properly. So that means you have to put the mask on. It can't be in your pocket. You have to wear it. Continue social distancing as often as you can. And if you can't, put on your mask. I told you about the gatherings I went to, even in the church. I was at a church and it was exposed. So, anyway, I went and got a PCR test after that. I have the home kit, but I said, no, I have been exposed now up front and personal 3 times within 3 days. I don't want to take any chances. All right. So understand and comply with contact tracing. If you know you've been exposed and you exposed someone else, notify them, let them know, notify your local health department. Wash your hands constantly. And there's testing available. As I said, I chose the PCR, but there's rapid antigen testing, and also monoclonal antibodies are available to you if you actually have contracted COVID. So with that, that ends this discussion. Do you have any questions for me? And I'll show you some of the references. I left off my CDC reference, but I do have references from the CDC on all the information that I presented.